Yes, hello. My name is Reinhard Busse. I'm a professor of healthcare management at the Berlin University of Technology and one of the co-directors of the European Observatory on Health Systems and Policies. I wish you well from around the world, here from Berlin to you in Seoul or wherever you listen and watch this presentation. I have been asked for this HERA symposium on the COVID-19 pandemic to talk about Germany's responses to COVID-19, and I will do so in comparison to other European countries. Clearly, how can we learn from other countries? If you do a symposium like you do, there is the idea that you look at other countries, compare data, and then to learn from them. If we take Germany in the middle of this figure here, clearly we see that there are certain countries which have worse numbers. The US, countries within Europe, Sweden, Italy, but some also have better numbers expressed here as a percentage of the population tested positive and the percentage of the population who died from the pandemic. And we see there are countries, Norway, Australia, or South Korea for that example. We can also look at the deaths day by day and see how this has developed. What I want to do is, while I concentrate on Germany, I take a view on Europe. So I compare Germany to other neighboring, otherwise quite similar European countries. So we have data, but we also need qualitative data. So we have quantitative data, we need qualitative data to understand the policies behind, which partly or to a large extent explain the differences in the figures we see. And I want to briefly introduce to you the COVID-19 Health System Response Monitor, which we at the European Observatory on Health Systems and Policies have developed in cooperation with and for the World Health Organization Regional Office for Europe and the European Commission. What is the COVID-19 Health System Response Monitor? It is an open access web-based platform drawing on the actual information which is provided, aiming to answer the needs of policymakers during the COVID-19 pandemic by capturing from public data what country health systems are doing and have been doing to meet the challenges. And we do so by collecting, organizing, and updating information. We allow policymakers to see what is happening in context through a set of cross-country analyses and giving users links to relevant COVID-19 information, key data, websites, articles, and we flag wider public health initiatives and good practices. And as I said, this one is done and delivered together with WHO Europe and the Directorate General Santé or Health of the European Commission. Who generates the data for this monitor? Well, the platform, which as I said is publicly available, depends on a network of academic institutions. It's usually the partner institutions of the European Observatory on Health Systems who are united in the Health Systems and Policy Monitor team, and its WHO country offices in other countries. It taps into their huge knowledge and credibility and their links to multiple complementary networks. All these people involved in the health system response monitor user template, which I will show you on the next slide, that outlines the basic questions and guides authors systematically through health system and non-health system responses. The data presented there is largely in the public domain, but national authors typically draw on additional academic and policy sources to draft the initial text. The observatory team in London, in Brussels, and in my own department in Berlin, we support the national authors and edit the text. And the text is reviewed also for quality, consistency, and policy relevance by our team. The monitor itself is based. You have several influences here, several slots here. One is on countries. So it's probably the most important one is to go country by country, and based on the template, the country pages display key health systems responses on preventing transmission, on maintaining the infrastructure and the workforce, delivering health services, paying for care, governance and the legal, regulatory and policy aspects, and measures in other sectors. There are updates on the latest policy responses and links to relevant data, articles, and background documents. So this is the background basically to what I will be talking about. Much of the material is in detail here, but we complement it by our own data. My team in Berlin is compiling on a daily basis data on hospitalizations, on ICU stays, on tests in a variety of European countries, and I will also use this material to put Germany into context. So there would be a range of topics when you say, I mean, the policy responses to COVID-19, and I've gone through them, clearly reaching from public health measures right down to the intensive care unit. So it's a typical public health topic. I want to concentrate really on the healthcare aspects of it, and even as this field is still too broad to cover, I concentrate more or less on three important issues. Number one is the testing. And there we have questions like the preconditions for eligibility. So which persons are eligible within the various countries to be tested, usually on public financing for these tests. By whom? Who is doing the test samples? What are the test capacities? And what are the conditions for people while they wait for the result? Germany, from its very beginning of the first case in late January in Bavaria, we followed this thorough testing strategy. And my colleague Christian Drosten has just developed the first PCR test a day before the first test appeared in Germany. And we also, from the beginning, were quite thorough, at least as long as the number of new cases allowed it, to do contract tracing. And as you see here, from a range of countries on a daily basis, we did much more testing than comparable countries I've marked here. So Germany is in green, I've marked here the UK in orange and France in red. The second block is treatment. So people who are tested positive, who is primarily responsible for treating them? Is it the ambulatory care sector, the primary care physicians, or is it the hospital sector? And what about the referral from one sector to another one? On the right-hand side, and this is in German only, I have one of the first guidelines from our National Public Health Institute. And until the end of February, these guidelines told the primary care physicians, who were from the beginning responsible to do the testing, that they should refer patients to hospital if tested positive. And we luckily, last minute almost, at the end of February, beginning of March, we changed that and told our primary care physicians, treat the people at home as long as possible and only refer them to hospital if really necessary. And this differentiates Germany from many other European countries, especially France, but also regions in Italy, Spain, where most of the test capacities were inside hospitals. And then when people were already there, they stayed there. And the third aspect I want to touch upon in this presentation is the relevance of hospital capacities, especially ICU and ventilation. There was lots of attention, especially in Germany. Germany has a huge hospital sector, and the Hospital Federation said, good that we have all these hospitals, good that we have all these ICU capacities. This will be our most important asset in fighting the pandemic. Here on the right-hand side, you see again in a comparative manner the ICU capacity per 100,000 population in Germany, which is the highest of any OECD countries. I put South Korea here for comparison, and you see it's like per population less than a third compared to Germany. And I put Ireland, and Ireland is about 1/7 per population compared to Germany. And so this one was seen based on the television pictures from Bergamo in Italy, that we thought hospitals would be the main point, the main fighting point for the pandemic. But we will see that this is not the most important factor. Usually, I mean, when we look at primary care or outpatient care versus hospital care, we see hospital capacities, and hospital utilization and primary care utilization also of measures of inefficiency. This one visualizes all the European Union countries. The EU average is marked here on the x-axis by the number of hospitalizations. So the average in the EU is 172 hospitalizations per 1,000 population per year, or 70.2 per 100. And on the y-axis, it's the outpatient contacts. The average there is 7.5 per person per year. And then you can use these to form quadrants. And you see Germany here in the upper right-hand quadrant, so high numbers of inpatient utilization, high numbers of outpatient utilization, while in the opposite quadrant, in the lower left-hand corner, for example, you find Denmark with below average inpatient and outpatient usage. Some visible countries were Italy and Spain at least in the beginning of the pandemic. These ones are, as you see here, they have lower than average hospital utilization, but in many parts of those countries, with big variation, as we will see, they still were hospital focused. So people were told to go to hospital, or felt they should go to hospital. Then we have France, and France, as you see here, is above average in inpatient utilization, below average in outpatient utilization. France was the country in Europe where the testing initially was 80% in hospitals, and 70% of all the people who were tested positive were hospitalized. And but we want to look here on Germany. So Germany, as I said, has both a big ambulatory and a big hospital sector. And almost by chance, you could say, we made the right decision, not in spite of all the propaganda or the policy talk about the hospitals. We made the right decision to use our strong ambulatory care sector and told the population, see your primary care physician if you have a suspicion of being infected. I use this flow chart here, and this one is at the height of the epidemic in early April. So in early April, these are daily numbers. We had 7 per 100,000 people tested positive per day, or 6,000. For each one of them, 14 people had been tested, and every fifth person who was tested positive was hospitalized. So around 1,200 per day. We now, at least in the first stage, they stayed 14 days, quite a long length of stay. Then again, 1 in 5 of those people who are hospitalized were ventilated. 1/4 of them were transferred before or during they were ventilated from one hospital, often with less experience, not as well equipped, no experience intensive care physicians, to larger, more experienced hospitals. And of those who were ventilated, initially 50% died. In total, at around that time, 4.5% died. In Germany, unlike some other countries, basically everybody who died in hospitals, and about 40% of those people who died in intensive care. When we compare this to the healthcare resources, the first thing is we see that only the hospitals were seeing 1 in 5 patients. So 4 in 5 patients were taken care of in the ambulatory care sector. Then in hospital, and I said these were 1,200 people, 1.4 per 100,000. They stayed 14 days, you could say. So 20 occupied beds per 100,000, which were at the height of the epidemic, 3% of the available beds. If you look at the entire period until the end of May, it's about 1.7% of all hospital beds, and we have to see 600 hospital admissions per 100. No, we have 600 beds per 100,000 people, and below you see how many people were hospitalized. We can do the same for the ICU capacities. I said we had about 35 per 100,000 capacities. We gave hospitals extra money to increase the number of intensive care beds. So at the end, we had about 40. And again, you see the calculation. We admitted 0.3 people per 100,000, 14 days length of stay. So this is about 4 occupied beds per 100,000 people, or 10% of all ICU beds. If you average it out until May, it's about 4% of ICU beds were utilized. I said we can do that for the first wave, and we have data until the end of May. We will now get new data, and this is the total figures on the upper side, and the daily figures on the lower side. So every day, 55,000 tests, 2,300 people tested positive, 440 people hospitalized, 90 people put on ICUs, and 105 people dying per day. How did this compare to other countries? And I said we learn also to mirror ourselves. What did we well what did we do well, what we could have done better, often by comparing ourselves with other countries. And I said we tested 14 people initially to find one positive case. When we compare this with other countries, in Europe, only Norway tested more people. And you see other numbers here. Italy, 1 in 4 people, so 25% were tested positive. The same in France, almost the same in Spain, in Austria, Netherlands, every 5th, in Denmark, every 9th. So there's a suspicion that they tested much more people with a high pre-test likelihood because they have symptoms, while Germany also tested contact persons, and so this explains why more people were tested negative. The numbers of infections, even though we all looked at the other countries, I mean, yes, in Spain they were higher, in Austria they were a bit higher. In Italy, on average, they were marginally higher. In Lombardy, yes, they were 3 times as high as in Germany. And UK, Netherlands, France, not much difference when you only look at the test positive numbers. Denmark and Norway even a bit lower. Then the hospitalization rate, I said 5 to 1 in Germany, so only 20% were hospitalized. When we look at France, it was 70%, or 2 out of 3 persons tested positive was hospitalized. In Spain, 1 in 2, in the Netherlands, 2 in 5, meaning 40%. In Italy, about 1 in 3, with large regional variation. So in Lombardy, where at least we in Europe looked upon, it was 50%, but in the neighboring Veneto region, it was like in Germany, only 20%. You see the figures here drastically differences in numbers depending on the strategy where countries tested and how much emphasis they put on their primary care sector. And last but not least, how many people were put on ICU in most countries. The percentage of those people hospitalized was lower than in Germany. In no European country, I mean, people had the feeling that the hospitals were the forefront of the COVID response. But when we really look at numbers, and these are the variety of European countries here, the available beds per 100,000 population are marked in yellow, and the daily numbers of occupied beds by COVID patients are marked in black here. And the maximum was in Italy, with 20% of hospital beds being utilized by COVID patients, 1 in 6 beds in France, and only 1 in 50 beds, remember the 1.7%, so even a bit less than 1 in 50 beds in Germany. For ICU capacities, it looked a bit different. Again, these are all the European countries for which we have data. In the red line shows the pre-existing ICU capacity per population. Again, Germany, marked in green here, has a very high capacity, while the neighboring Netherlands, also neighboring on this slide here, had a very low initial capacity. And we see the ICU numbers per day, again with a black line, and you see that the black line in the Netherlands, as well as in the Lombardy region in Italy and in Sweden, crossed the red line. So the ICU capacities had to be created. There was a surge in ICU capacity to make up for all these patients. While in Germany, you see that, I mean, the maximum capacity usage of ICUs was 10%. Then, and probably this is the ultimate litmus test, the excess mortality. I mean, we can look at the fatality rates. We can use the COVID death rates by themselves, but we can also compare them together with all the other people dying in a country to the rates who are usually dying. And this is a range here of European countries, and the percentages I marked here is for most countries in the period until the end of August, how many people died more than in the previous years. And you see here Spain plus 26%, UK plus 24%, Belgium plus 18%, Italy plus 24%, and a few other countries. I also put the absolute numbers there, and we compare that to countries like Germany, Norway, Denmark, where there is no excess capacity. Excess mortality, sorry. So there's exactly the same number of people dying as in previous years. There was discussion in many countries, including Germany, whether the postponement of elective surgery, that we saw fewer people from certain conditions like myocardial infarction, stroke, whether we wouldn't see an increase in death rates from other conditions, but also these would show in excess mortality. And that this is not the case shows that the reduction in hospital utilization from other patients was not the harm of the other patients. So what can we learn from all this? Well, the first thing I think we have all learned, and especially in Germany with our public health offices, regionally responsible county by county for the contact tracing and telling people to get tested, that functioning systems of public health are critical components of health system responses to epidemics. Where responses to COVID-19 were successful in the first wave, and in Germany they were, compared to neighboring countries, relatively successful. This appears not just due to clinical care capacity. While we all looked at hospital care, it turned out that the public health office capacities were much more relevant, but also, or even more, to capacity in other parts in the health system that have prevented high rates of hospital admission becoming necessary and reserved or safeguarded hospital facilities, including ICU care for those patients needing it most. The backbone of the COVID-19 response strategy in Germany was outpatient services, not inpatient services. Only 1 in 5 COVID cases, as I showed you, were actually treated in hospital. The success of the German response strategy, in other words, was the ability to keep the majority of people out of hospital and at home. This was possible due to the availability of regional public health services, as mentioned above, which had been neglected by policymakers, professionals, and the public alike for a long time. And they were able to conduct contact tracing and work in coordination with outpatient services, which was in charge of the testing. Why is testing important? I think we all know that now. It gives us a truer epidemiological picture and thus helps to better prepare the response in terms of necessary capacities. And we test to prevent people from spreading the disease. But as important, if people get tested outside the hospital, it gives them a diagnosis and prevents them from going to hospital with unclear symptoms. And many of these people, I think, who we saw in Lombardy in the beginning, it was not necessary that they went to hospital, and they might have got infected there. And why is keeping in suspected and actual COVID patients out of hospital as long as possible? Well, we all know hospitals are dangerous places. From the viewpoint of COVID, all other patients in hospital are risk persons. They are at risk for getting COVID, and if they catch the virus, they will have a severe cause of the disease. And we saw that, and this is my last remark. So I was quite positive here on the German case, as you have seen, but we also saw a drastic negative example. In Potsdam, the place where I live, we saw a hospital where 47 people died from COVID. And the tragic thing is that only 3 of them entered the hospital due to COVID. 44 people caught the virus while they were in hospital for other reasons and died. And a total of 138 people got infected there. So, I mean, this, I think, is a drastic reminder that even countries who might have a very good or moderately good response to the pandemic, that things can go wrong. And we must be very careful all the time. Thank you for listening, and I will be available for questions later. Thank you.